I'm Dr. Alan Bonder. I am the Associate Professor of Medicine and Medical Director of Liver Transplant at Beth Israel Deaconess Medical Center, and I'll be happy to talk to you an update on autoimmune hepatitis. Also would like to thank the organizing committee for bringing you back again for this year's lecture. Here's my conflicts of interest. Let's just start with autoimmune hepatitis can affect all populations, all ethnic groups, or all ages. So we know that autoimmune hepatitis has been recently considered a rare condition. As you can see from this is the Danish registry, the kind of incidence is between 15 to 25 per 100,000. We know the autoimmune hepatitis is a non-resolving chronic liver disease that affects both genders with a female predominance. We know it's going up in incidence and has a bimodal age of distribution. So I want to just kind of center your attention to the first graph in your left side. And as you can see, overall, the black lines show us there is a total increase of number of patients with autoimmune hepatitis. And if you look back at the pointing line on top of the black line, you can see that it is more predominant in females. And in the graph in your right-hand side from the Danish registry show this bimodal kind of distribution. So we've seen more people diagnosed in their fourth decade of life, and also we're seeing a really huge peak in patients who are between the sixth and the eighth decade of life. So based on this trend that I just showed you, is there has been some studies looking at the criteria to see they fit, and actually what I've shown is that patients, again, in the fourth and the sixth decade of life have an increased prevalence of autoimmune hepatitis. Your graph in the left-hand side shows that age 40 to 49 going up to 50 to 59 and 60 to 69 is actually going up. And again, the graph in the right-hand side, when we actually tier this kind of graph, we see that, again, the female predominance of this condition is going up exactly at the same bimodal age of distribution. So we know that the age is a problem. Well, ethnic groups at ages of presentation also may be different. So we know that patients with Alaska Native descent have a higher frequency of heteric autoimmune hepatitis at presentations. We know that Hispanics are more commonly present with cirrhosis, most likely related to they present late to the healthcare systems. And finally, we know the African Americans have an accelerated progression of disease and higher rates of recurrence after liver transplantation based on the registry data that I just showed you. So I just showed you that there are ethnic, there are ages, but we know that autoimmune hepatitis is a genetic condition, but we know it is, I picture this as a closed door that will need a key. So the closed door is in this side. If you look at the this table, this graph, you know, the genetic predisposition, if you look at the HLA and the different distribution is very similar to the autoimmune conditions, but we need the key to open this genetic predispositions. In your right-hand side, you can see some extrinsic triggers. For example, we'll talk about certain medications. Now there is a lot of data about the gut microbiome. There's a lot of different infections, and we will talk about this type of extrinsic factors. But also at the same time, there has to be some type of intrinsic triggers that helps dysregulate this immune cell activity and dysregulate the cytokine production that a patient needs to develop autoimmune hepatitis. So when we talk about type of autoimmune hepatitis, we know that in the literature, it used to be type 3, but now based on the most recent guidelines, we have two types of autoimmune hepatitis, type 1 and type 2. And when you look at the different features for each one, we know that type 1 is more common in adults, type 2 is more common in kids. The age presentation in type 1 is more peripubertal in adults versus type 2 is more usually under 14 days of age. The presentations in type 1 is with chronic liver disease, asymptomatic, acute severe with liver failure, and patients with type 2 is more like acute liver or relapse and frequent elevation of the liver test. The laboratory features in type 1 is more of a hypergammaglobulinemia, whereas in type 2 is a reduced levels of IgA. And this is one of the key things the antibodies features the ANA, the smooth muscle, the anti-actin, and the soluble liver antigen are more present in type 1. In the type 2, we have the anti-LKM, which is more common in kids. And finally, concurrent immune disorders. In the type 1, we have more presence of autoimmune thyroiditis, rheumatologic diseases, and inflammatory bowel disease. And we compared it to type 2, which is basically have diabetes and vitiligo. The overlap with other specific autoimmune liver disorders, specifically about PBC, is more common in type 1 versus basically type 2 is an atypical. And finally, remission after drug withdrawal, it is possible in type 1 and is very rare in type 2. And usually for those patients who have type 2 autoimmune hepatitis, will need long-term immunosuppression. So let's just start at how we evaluate autoimmune hepatitis. A patient shows up in our clinics. They're either asymptomatic or very nonspecific symptoms. They have an elevated AST, ALT, elevated IgG. The first thing we need to do is exclude viral, drug-induced, hereditary, and metabolic diseases. And once we suspect autoimmune hepatitis, we will send serologic markers, the ones that I just basically went over in those tables. And finally, if we do think about autoimmune hepatitis, I want to make sure we emphasize that there is no diagnosis of autoimmune hepatitis without the presence of histologic features on a liver biopsy. Suspecting autoimmune hepatitis, on your left-hand side, if you follow the algorithm, you have the serologic markers. If you have a type 1 in adults, a positive ANA, a positive IgG, and your pediatrics, you have a positive LKM. If they are positive with findings on liver biopsy, specifically of an interface hepatitis with a plasma cell-rich hepatitis, that gives you a diagnosis of autoimmune hepatitis. But I want to also stress the importance, even if they are autoimmune markers, but the liver biopsy does not show interface hepatitis or plasma cell hepatitis, their other diagnostic should be considered. And I want to spend one slide with a kind of the histologic hallmarks of autoimmune hepatitis, because again, as I told you, without the presence of histological findings of autoimmune hepatitis, the diagnosis cannot be made. So on the box level A, we see a typical histological demonstration of interface hepatitis with kind of plasma cell hepatitis. In the box level B, we see what's called the typical features of an autoimmune hepatitis. That you find it, that should ring to your ears that this is autoimmune hepatitis, specifically about the resetting of the hepatocytes. And finally, in box C, you see the pericentral hepatitis, the necrosis seen in someone who has severe autoimmune hepatitis. And with all those three things, what are very characteristic of autoimmune hepatitis, I want to also bring to your attention that this sometimes could be indistinguishable for someone who has drug-induced liver injury. So we're going to have to put the pieces together to make sure we give the right diagnoses. So let's say that patient came in and the first set of markers, specifically anti-antibody markers, were all negative. We're talking about the ANA, the smooth muscle, the LKM. There's kind of a second round of markers that we can do. For example, going all the way to the left-hand side of your algorithm, there is an antibody called soluble liver antigen, which is present in 15-20%. The carries actually a straightforward diagnosis of autoimmune hepatitis. But let's say we did send markers and we send a p-ANCA. A p-ANCA is non-specific or AIH, but can actually start thinking about a PSC. If the celiac testing TTGs come back positive, we can think about celiac disease. And finally, if the AMA is positive, we can even think an overlap with PBC, a PBC by itself, and also sometimes autoimmune cholangitis, which is not typical features of autoimmune hepatitis. But I want to lift up to the right that there are sometimes patients who have autoimmune hepatitis who their antibody screens are negative, but they have histologic features of autoimmune hepatitis, and those patients should be treated as autoimmune hepatitis. And again, I want to play like a puzzle with the findings that we get with liver biopsy with the autoantibodies. So in your green box, you can see the different autoantibody markers. And if you have that liver biopsy specifically with interface hepatitis, the diagnosis of autoimmune hepatitis. But let's think about if we have autoantibodies, but the liver biopsy does not show AIH features, but shows bile duct or injury loss. we need to start thinking about other cholestatic or overlap things, symptoms such as PBC or PSC. And something that we should not miss today with the metabolic kind of epidemic that we're getting is we actually see a fair amount of patients with autoimmune hepatitis with MASH features that can give you overlap syndrome between autoimmune hepatitis and MASLD. So I just show you the markers, I just show you histologic features, and there are other tools that we can use. Left-hand side, this is the first kind of diagnostic criteria that were used in the late 90s by the Mayo people. And as you can see, this is a very complicated table when you have 33 different parts of that. And again, not very kind of clinically relevant. And on your right-hand side was a simplified criteria that were just published in 2008, which is easier to use, 7 kind of features. And again, the probable diagnosis is 6, definite diagnosis out of 7. I want to just point out that both two tools are only used for research purposes and should not be used in clinical care, as they're not being validated in large cohorts with clinical care settings. Do we have any other tools to evaluate stage? So we know that kind of the fifth vital sign in any liver kind of clinic is the FibroScan or the elastography. And there have been some studies looking at the transient elastography scores in the stage and treatment response. I'm going to point out the left side of the slide. You can see 22 patients who actually were completely on remission. They had an kind of transient elastography score that was less than 4, and that correlated with biopsy findings of histological remission. And your right-hand side, you see 38 patients who had no biochemical remission. They had an elevated kilopascal score that show high histological activity. So we can just point out that we can use a FibroScan to tell us if there is histological remission. And also, I'm going to take you to the right hand of the slide. You can see that the changes in the liver stiffness over time can point us if there has been actually biochemical remission. So you see the blue graph, it's those patients who had no biochemical remission and their kilopascals were still going up despite almost more than 4 years of therapy. And the black line, you can see there is biochemical remission. You can see the liver stiffness going down as the patients are getting treated with immunosuppression. And you can see that those patients are, in fact, in biochemical remission when they compare that to or match it to their liver biopsy findings. So I just point you out that the FibroScan is a great tool to kind of stage their disease, but is there a specific time where the transient elastography is better to use? And this is a really important study where they looked at patients who came in after diagnosis of autoimmune hepatitis to just try to stage the disease and making sure they don't have advanced fibrosis. And they actually divided in 2 groups. The first group was those patients who actually had a FibroScan less than 3 months of therapy, and those patients who had more than 6 months of therapy. You can see the area under the curve or less than 3 months was 80% versus the area under the curve and all those patients who were treated for more than 6 months were 90%. And based on this study, we can say that a kilopascals of 16 at 6 months had a 98% sensitivity and specificity of diagnosing advanced fibrosis in those patients who had autoimmune hepatitis. Based on this study, we will actually say that FibroScans/elastography should be useful exactly after 6 months of therapy or longer. So how those patients present to our clinics? So there's different clinical phenotypes. There's a broad range from asymptomatic to acute, severe, or even fulminant liver failure. So let's just start with the rule of thirds. A third of patients will present what's called the incident onset, which I would say in my clinical practice is the most clinical phenotype. They come in, they have really non-specific symptoms, they feel ill, right upper quadrant pain, lethargy, malaise, anorexia, weight loss. They might have some fluctuating jaundice, but they really just, based on the abnormal liver test, will do the workup and will find autoimmune hepatitis. The second third of those patients who have an acute onset, they are a little bit sicker. They're an acute exacerbation of their chronic disease. we have to treat them, but when we look at their biopsy, there are a lot of inflammation, a lot of necrosis. And again, some of them either will have the autoantibodies or some of them will lack of them. And finally, the last third, which is kind of the scary ones, those patients who've had autoimmune hepatitis for years, maybe they did not seek any medical attention, they didn't have a lot of symptoms, and now they're presenting with symptoms of chronic liver disease, jaundice, encephalopathy, ascites, which basically just those patients, by the time they present, they will need some type of liver transplant evaluation. So on top of the clinical presentation, we can basically frame it based on the time. We have the acute phase, those patients who are really sick, acute ecteric hepatitis, acute severe autoimmune hepatitis with or without the presence of liver failure. And again, we have the chronic patients who present with chronic hepatitis and chronic liver disease with complications of cirrhosis, such as ascites, lower extremity edema, variceal bleeds, and hepatic encephalopathy. And I want to just point out some special situations because this is something that we see, I would say, I'm biased because I do more the autoimmune hepatitis, but we see kind of frequently in our clinics. For example, onset of disease after viral infections. We just finished one of the major epidemics. I've seen a lot of autoimmune hepatitis after a major COVID infections, hepatitis A infections. So any case that actually is a viral infection, as I point out at the beginning of the presentation, can trigger this regulatory immune response that can basically make sure that you get autoimmune hepatitis. I've seen a quite significant amount of patients after a certain amount of medications or either herbals, specifically the medications that go into my mind are the nitrofurantoin and minocycline, which is the classic ones, but today, all the biologic agents they're being using for rheumatoid conditions or inflammatory bowel disease are kind of a really good example of them. Interferon alpha, which is barely used these days. And then there's some other concurrent autoimmune things. So let's say a patient has rheumatoid arthritis and presents with elevated liver test. This special situation should be worked up for an autoimmune hepatitis. And finally, an unusual but case that we need to think about it is that 10 to 20% of patients, they can present with this APOSET, which is an autoimmune polyneuropathy, candidiasis, or ectodermal dystrophy. So look at drug-induced autoimmune hepatitis. I want to kind of look at the medications that can definitely associate it to this: minocycline, nitrofurantoin, infliximab, methyldopa, adalimumab, and Allerton. I want to point out the probable association because we are seeing a huge amount of patients getting treated with statins. And as you can see, statins are definitely can trigger an autoimmune response. And finally, I'll talk a little bit about checkpoint inhibitors because that can basically take an entire presentation, but checkpoint inhibitor is more with all the current cancers as being really a new trend about bringing autoimmune hepatitis to our head. How can we differentiate between a drug-induced and autoimmune hepatitis? So I want to try to kind of tease them out one by one. So the gender usually, again, is female predominance. Usually the onset is kind of really fast. You take the drug and suddenly 4 to 6 weeks later, boom, you actually develop autoimmune hepatitis. Usually you don't have autoantibodies. And usually there is a rare cirrhosis of presentation. And usually by the time you stop the medication and you need to use glucocorticoids, that will be enough to treat the drug-induced autoimmune hepatitis. And usually the progression to cirrhosis is rare and the survival with transplantation is pretty good. Versus autoimmune hepatitis, we know that those patients basically will need glucocorticoids, will need some type of immunomodulator therapy. We know that there is relapse after withdrawal of medications. We know they can progress to cirrhosis. And we know the progression, the survival is great, but usually survival is great on top of needing a liver transplant. I want to just kind of point out 2 slides about checkpoint inhibitors because basically this is the most recent American Society of Clinical Oncology grading system. It's divided into 4 grades. The grades depend on if they're asymptomatic, grade 1 and grade 2, they're asymptomatic. The laboratory data is based to 1.5 to 3, 1.5 to 3. And the management really at the grade 1 and grade 2 is you can still continue the checkpoint inhibitor therapy while monitoring. The grade 2, you can hold off, but you can kind of either treat with steroids or basically re-challenge them. But grade 3s and grade 4s is you basically, they are symptomatic, can show signs and symptoms of decompensated liver disease. You need to permanently discontinue the checkpoint inhibitors, treat with steroids. And again, I want to make sure that there should not be any more challenges for any other checkpoint inhibitors because the recurrence could be fatal. And finally, the treatment of checkpoint inhibitor. I mean, there has been a trend about should I use higher dose of steroids? This is a study was just published a few years ago looking at grade 3 or higher in 215 patients, and they divided in high dose versus low dose. You can see the left-hand side is 2 milligrams per kilogram. The right-hand side was 1 milligram per kilogram. So the results of the study showed no difference in development of steroid refractory hepatitis. There was no difference in time of resolution of hepatitis, but did show that higher dose group more likely to develop steroid-related complications, included hyperglycemias and infections. So I think we need to kind of take a step back. Don't basically flood them with high doses of steroids. We need to basically start with a 1 milligram per kilogram and follow their labs very closely. So how do we treat autoimmune hepatitis? So the first thing is, based on the most recent guidelines, there is some kind of like things that we need to do, like housekeeping notes or housekeeping rules that I would recommend. We are thinking about using azathioprine or 6-MP, so we need to make sure that we check them for TMPT activity to make sure they don't gonna get any toxicity. Number 2 is we need to make sure they don't have any hepatitis B because their presence should be trigger treatment before starting immunomodulators, immunosuppression therapy. And finally, number 3, we need to perform a bone mineral densitometry because we know that patients with autoimmune hepatitis are more at risk of osteoporosis. So we need to make sure that we treat that accordingly before we start therapy. So I'm going to start with an algorithm. Let's say the patient who was diagnosed with autoimmune hepatitis and doesn't have cirrhosis can basically, if a patient with autoimmune hepatitis who's coming in for therapy. So the first question we need to ask ourselves, does the patient have either cirrhosis or acute severe autoimmune hepatitis? If the answer to that question is yes, we need to avoid budesonide. There has been studies linked that portal vein thrombosis to it. We need to avoid azathioprine because those patients will have more side effects. If the answer is no, we can start monotherapy. My preference is to start prednisone at the lower dose, 20 to 40 milligrams, and see if the patients go into biochemical remission for the next 4 to 8 weeks. There has been some studies looking at combination therapy between prednisone and azathioprine. There's no differences in biochemical remission, but there are some minor differences and relapses. So my recommendation is to do some type of monotherapy, follow their liver test, and once we think about their own biochemical remission, then we start tapering the prednisone and we start azathioprine. I still recommend checking their labs every 2 to 4 weeks, making sure that the biochemical remission was achieved. And if that's achieved, then basically we'll go into maintenance therapy, which is basically we'll discontinue the prednisone, we'll continue immunomodulators, and then we will try to keep in biochemical remission. And if that's the case, we can consider immunosuppression withdrawal if, plus or minus a biopsy, if actually that's the case. If those patients do not achieve biochemical remission, I will actually have some slides about how we consider second-line therapy. So for those patients who do not achieve biochemical remission, and is again, those patients who do not have a normal ALT and a normal IgG, we have other options. This is a study that we were part of that Efi from Turkey published and looked at 200 patients, and he divided them in 2 groups. The first group is those patients who had adverse events to standard care, either azathioprine or 6-MP, but was still able to get some type of biochemical remission. And group 2 of those patients who did not have side effects, but not able to get into biochemical remission. So you can see the results down in the graph below in your left-hand side is for group 1, so those patients who started mycophenolate, who were responders but had a side effect, they will still have higher biochemical remission rates, up to 90%, and also a little bit more than 95% in tacrolimus arms. But I want to just point out the group 2, those patients who did not respond to azathioprine or 6-MP plus prednisone, those patients who were re-challenged with MMF only maybe close to 38%, and tacrolimus close to 60%. And when they look back, both medications, both MMF and tacrolimus, there was no difference in liver-related deaths or instead of a liver transplant in either groups. So based on this study, we would recommend using tacrolimus as a second-line therapy if patients do not achieve a biochemical response. So I've actually continued to use a lot of prednisone, but again, budesonide, which is a medication they made up to our guidelines, was on this hallmark study by Michael Mans in Germany. In this study, he looked at 6 months prospective double-blind randomized controlled trial, and his endpoint was 6 months complete biochemical remission, and he basically divided those patients in 2 groups. The first group is budesonide with azathioprine, weight base, same as all the other patient, and in the second group is the standard prednisone starting at 40, tapering down with the same dose of azathioprine, 1 to 2 milligrams per kilogram per body weight per day. And what he showed in his study looked at, remember, the first kind of objective are 6 months patients with biochemical remission. The first graph to your left, you can see that the budesonide was superior to prednisone in both the intention to treat and at the end of the analysis. In the middle graph, you can see that when he divided both males and females, both in the budesonides and both the prednisone groups, both budesonide was superior, achieving a biochemical response. And finally, for those patients who were not able to be responders, but at least trying to get the liver test close to normal, were superior budesonide to prednisone. So based on this hallmark study, budesonide has made it to our clinical guidelines, is now currently recommended as first-line therapy in those patients who do not have advanced fibrosis or cirrhosis because of the risk of portal vein thrombosis. But is there more data besides that one really hallmark study? So when I look back at meta-analysis, this is the amount of records that we can see, 2 quantitative synthesis. You can look at the biochemical remission. It's a 2.1 odds ratio in those patients using budesonide. There are higher steroid-specific side effects in the prednisone group. But in conclusions, what we can say, there are few qualified studies. There is insufficient evidence for long-term outcome, lack of histological resolution. We don't know the progression to cirrhosis, death, or liver transplant. So overall, we can say that budesonide's basically grade of evidence is a low grade of evidence. And finally, this is something that really makes the people who in the autoimmune world really happy. This is the first study looking at azathioprine versus mycophenolate in 6 months, looking at biochemical remission. So this is the first study looking at naive patients who were diagnosed, who were randomized to either azathioprine plus a prednisone taper versus mycophenolate plus a prednisone taper. You can see there was 31 in the azathioprine, 39 in mycophenolate. The primary outcome of this study was the percentage of patients who had a normal ALT and IgG after 24 weeks of therapy. And then the graph in the right-hand side, you can see there was a significant difference in the mycophenolate group, close to 60% versus 30%. The secondary outcomes also less serious side effects occurred in the patients with MMF. In cessation to therapy, usually was more common in the azathioprine compared to the MMF. So again, this study was just published in the fall of last year, so has not made it to our guidelines, but it's something to start thinking about. The mycophenolate maybe is a better option compared to the azathioprine or 6-MP. Finally, we'll talk about treatment withdrawal. And when I talk about treatment withdrawal in patients in my clinic, I tell them that the relapse rate is high, and I tell them that this is like one strike and you're out. I would not basically expect multiple trials of withdrawal for therapy, because if that happens, then the patient can develop advanced fibrosis. So how do we define relapse? We define relapse of a reappearance of an elevated ALT 3 times above upper limit of normal, an IgG 2 times upper limit of normal. And usually what we've seen in the trials or in the data is the relapse occurs within 12 months. And once relapse occurs, as I told you, lifelong surveillance is needed and lifelong therapy should be installed. And then it is very important to try to get them detected earlier, because the earlier we detect the relapse, the lower the immunosuppression or the prednisone that we will use, and then those patients can go into remission faster. So this is the algorithm that will present to you about how to follow up a patient who's in remission. So in your right-hand side starts with normal ALT, reducing or maintaining an immunosuppression level for at least 2 years to 3 years. You taper out you actually, you maintain stable remission. And basically, those patients who relapse, you can induce them again with prednisone or budesonide if needed, pull them back on remission, taper off the steroids, get an immune modulators. And again, as I told you, I don't really try more than once. I usually keep them on maintenance therapy for the rest of their lives. There has been some debate about using a liver biopsy to see if patients basically can stay in remission. And basically, the data was that patients who had a liver biopsy, they showed a little bit of histologic features of inflammation, have a 30 versus 21% relapse, which is not statistically significant. So some of us in the clinics are basically trying to take patients or withdraw them medications without a liver biopsy, and then follow them closely. The only caveat to that is a type 2 autoimmune hepatitis, as some of those patients, they might need a liver biopsy because their actually relapses are higher, although we should not try to take them off as type 1s as we should. And let's just talk a little bit about special considers of severe autoimmune hepatitis. So I want to stress the importance because the presence of autoimmune hepatitis with an elevated INR, it is called acute severe hepatitis. And with the presence of encephalopathy, that's acute liver failure, those patients should be sent to a liver transplant center or should be evaluated for liver transplant. For those patients who do not have hepatic encephalopathy, have acute severe autoimmune hepatitis, they might benefit high doses glucocorticoids if they consider responders, and we can say if they can actually need a liver transplant. So you can see this is very kind of like, not a lot of kind of guidance. So this is when the Surfasa score comes into play. The Surfasa score was developed. You can see it's a very complicated score, which looks like our basically your bilirubin and your INR trend in day 1 and day 3. And they, based on this score, you can develop two types of Surfasa score, less than 0.9 and more than 0.9. If your Surfasa score at day 3 is less than 0.9, you can see that their survival and their response probability is pretty high compared to someone who actually led more than 0.9. And in those patients, when you look, for example, a Surfasa score of 1.85 or a Surfasa score above 1, you can say that actually those patients have a higher degree of mortality without liver transplant. And those patients should be referred to liver transplant immediately and try to work them up and get enlisted as soon as possible. So in summary, the take-home messages. Diagnostic score systems should be used only for research studies and in challenging cases of autoimmune hepatitis. We know the use of elastography can be used to assess the level of fibrosis in patients with autoimmune hepatitis only after 6 months of initiation therapy. First-line therapy consists of combination therapy with either prednisone or budesonide plus azathioprine, and in some cases, as I show you, I think the mycophenolate will come into play in the most recent in the future guidelines. Before starting therapy, specifically azathioprine, TPMT, the thiopurine methyltransferase activity should be tested. Budesonide should be avoided in patients with autoimmune hepatitis and cirrhosis and severe acute hepatitis at the high risk of portal vein thrombosis. And finally, mycophenolate mofetil and tacrolimus can be used as second-line therapy. With this, I would like to thank you so much for your attention, and we'll be happy to answer questions once we have the time for that. Thank you very much, and hope to hear from you soon.